It is actually my pleasure today to introduce Dr. Holly Koncicki, who will be speaking to us on decision-making in the elderly patient with CKD. Dr. Koncicki is a graduate of the Rutgers Medical School, and she did her residency as well as dual fellowships in nephrology and palliative care at Mount Sinai. She's an associate professor at Mount Sinai with dual appointments in both nephrology and palliative care, and she is very well known nationally as well as internationally as an expert regarding renal replacement decision-making. She's published and lectured extensively in these areas. I myself have had the pleasure of hearing Dr. Koncicki speak on a number of occasions, and I know you really enjoyed today's talk. So without further ado, Dr. Koncicki, please.
Thank you so much. It's a pleasure to be here today. Just going to share my screen. Okay, so as Dr. Meisels had said, we're going to be speaking about decision-making in elderly patients with advanced kidney disease and the role for palliative care. I have no appropriate disclosures. At the end of this session, I hope that you will be able to explain the complexities around the chronic dialysis of the elderly patients. You should be able to identify patients who are at high risk of poor outcomes with dialysis, and you should be able to utilize a decision-making framework about the treatment of advanced kidney disease in this population. Now, a perhaps underappreciated fact is that chronic kidney disease in itself is a life-limiting condition. So for example, the average 50-year-old with normal kidney function has an average life expectancy of about 35 years. When you look at the same 50-year-old with a GFR less than 60 or a GFR less than 60 with albuminuria, their life expectancy is shortened by between 5 to 10 years. Now, that being said, dialysis is a really remarkable therapy, but it will not restore normal life expectancy. In fact, we see that the highest mortality after the initiation of dialysis is in those first 2 months. So the decision to start dialysis is really a heavy decision to make. Now, previously, there was this dichotomy of thought that palliative care and disease-specific care were two separate entities. But now we know, and the model of practice is that palliative care can be provided at any age and at any stage of illness, including alongside curative care. Given that chronic kidney disease does have a decreased life expectancy, and given that our studies show that patients with chronic kidney disease have a symptom burden comparable to that of patients with malignancy, palliative care is appropriate to incorporate early in the treatment process. So let's introduce you to our first patient. This is an 89-year-old female with a history of a large hepatic cyst, hypothyroidism, pernicious anemia, and hypertension, who is referred to you, the nephrologist, from her primary care doctor for elevated creatinine. Her son is with her at the visit, and he is very concerned because the primary care doctor told them that mom has stage 3 chronic kidney disease. And he's been on Google and he's read all about it, and he knows that this means mom might progress to dialysis and wants to know what she can change in her lifestyle, including diet. You review her labs and you notice that her creatinine is 1.15, her BUN is 32, which gives her a GFR of about 42. Electrolytes are otherwise normal, her hemoglobin is normal, and her urine is without blood or protein. When you look back at her labs, you notice that her creatinine has been stable over the last 3 years or so. So the big question that I have is, are we overdiagnosing chronic kidney disease in the elderly? We know that GFR changes as we get older. There is an expected decline in renal function, which is normal. That being said, over 50% of adults over the age of 70 are classified as having chronic kidney disease, meaning they have a GFR less than 60. I think that our responsibility is to determine who has clinically significant chronic kidney disease that places patients at risk of either increased mortality or an increased risk of proceeding to need dialysis, versus those patients that have just an age-related decline in their kidney function. So what we see is that starting at about age 40, the GFR will decline by about 6 to 7 points every 10 years. When we look at autopsy studies or studies looking at transplanted kidneys, we find that as we get older, there's increasing scar tissue in the kidney, but not other findings consistent with another systemic disease state. Now, that being said, even though there is an age-related decline, we also know that our older patients are at risk of developing chronic kidney disease for other reasons. People are living longer with other diseases like diabetes, hypertension. Metabolism of medication is different in older patients, so they will be at an increased risk of acute kidney injury. But it might be time to redefine what normal is in terms of kidney function. When we look at patients between 65 and 75 years old in population studies, we see that the range of GFR varies. And when we look at age as we get older, we can see that there is also decreasing, decreasing upper limits of a normal GFR. So again, what might be considered normal in a 20 or 30-year-old may not be a normal kidney function in someone in their 80s. So this is a question for the group. It's not a poll because I'm not that fancy, but just think in your head what the answer would be. Who is least likely to need dialysis in their lifetime? Would it be a 40-year-old male with a GFR of 40, a 55-year-old with a GFR of 30, a 65-year-old with a GFR of 15, or a 75-year-old with a GFR of 25? And the answer is the 75-year-old. So let's see how we found this out. Now, this was a study looking at veterans who had chronic kidney disease stage 3 to 5. And over 50% of these patients were older, over the age of 75. And what the researchers sought to determine was at what level of GFR at varying ages were patients at an increased risk of proceeding to needing dialysis or progressing to end-stage kidney disease. So you have GFR here on the left, you have age on the bottom. The black is that the risk of dying before progressing to dialysis, the risk is greater in dying before ever needing dialysis, and the bottom is that it was likely that you would need dialysis in their lifetime. And what they found was that at different ages, there were different GFR levels. So for example, okay, sorry about that. So in patients between 18 and 44 years old, so under 45, a GFR of less than 45 meant that those patients were at an increased risk of progressing to dialysis in their lifetime. But when we look at patients older, from 65 to 74, we find that the GFR level was much lower. So their GFR level had to be around 20 to put them at an increased risk of progressing to needing dialysis. And for those patients over the age of 85, it was usually highly unlikely that they would need dialysis regardless of the GFR that they had. So that being said, I think it's time to kind of reframe how we approach our patients with, decreased GFR levels on our labs and older patients that carry this diagnosis of chronic kidney disease. We see that 30% of octogenarians classified with chronic kidney disease will die with a fistula in their arm that was placed that was never used. So these patients were being prepared for dialysis, had surgery, but they never progressed to needing dialysis. Now, that being said, we can't predict 100% what's going to happen. There is an unpredictable trajectory in terms of the renal trajectory of older patients, such that about 50% of patients over the age of 77 will have an episode of acute kidney injury in the 6 months prior to them starting dialysis, which kind of expedite their renal decline. But what I suggest is that instead of treating everybody the same with a check mark, their GFR is 30, we need to start talking about referring them to a nephrologist, or we need to start talking about dialysis. We should instead be tailoring our conversations more to, what if you outlive your kidneys? What would you want then? Now, all of this being said, I just spent quite a long time talking about how a decreased GFR level in the older patients does not necessarily mean that they're going to need dialysis. But what do we see? We see that patients over the age of 75 is actually the fastest growing dialysis population. In fact, over a 30-year period, this group increased by over 300%. So why is that the case? So what we find is that older patients are actually started on dialysis earlier, meaning they're started on dialysis at higher levels of kidney function than younger patients. Why is this the case? Could it be that the accuracy of creatinine and GFR calculations in the elderly are not the same, that maybe there's a better way to measure kidney function, and that may be true. Could it be that being older with comorbid conditions precipitates symptoms of renal failure earlier? Perhaps, but what I think is what's really driving this is that we are confusing uremia with the presence of underlying geriatric syndromes. So let's dig a little bit more into that. So one of the most common geriatric syndromes is the syndrome of frailty. The syndrome of frailty was described in the general population as meeting at least 3 of the following criteria. And when you hear this criteria, think also about the symptoms that you screen for when somebody's kidney function is low. So it includes unintentional weight loss, weakness, slowness, sarcopenia or loss of muscle mass, poor endurance or exhaustion, and low activity, right? So they sound pretty similar. So in the general population, frailty has been described to be associated with various poor outcomes, including increased hospitalizations and increased mortality. What we find is that in chronic kidney disease patients over the age of 65, frailty is about twice as prevalent compared to age-matched controls with normal renal function. What's also interesting is that we see the presence of frailty even in our younger patients with chronic kidney disease. Patients with frailty are started on dialysis earlier at higher levels of kidney function, but as we will learn, have worse outcomes with an increased 1-year mortality. So I would suggest that when we're meeting patients who are older, really doing a full geriatric assessment, looking at their activities of daily living, their mobility, mood disorders, nutritional status, can really provide a framework as to where they are that we can follow with time to try to help differentiate what's from an underlying geriatric syndrome and what's from a decline in kidney function. We find that most older patients over the age of 65 who are on dialysis have at least 2 geriatric impairments. Over 50% of these patients are frail. 80% require help with at least 1 IADL, which are activities that you need for independent living, so like food prep, shopping, finances. 67% have cognitive impairment, and a third have had a fall in the last 6 months. We also see that these presence of geriatric impairments in our dialysis patients places them at an increased risk of hospitalizations. So needing help with your ADLs, IADLs, the presence of depressive symptoms, or the presence of frailty places patients at twice the risk of hospitalizations. We also find that older patients who meet criteria for frailty are twice as likely to fail home dialysis modalities such as peritoneal dialysis. In terms of transplant, patients who meet criteria for frailty are 38% less likely to be listed for transplant. If listed, they are 35% less likely to be transplanted, and they have an increased waitlist mortality. For those patients who meet criteria for frailty that do receive a transplant, we find that they have a rough post-transplant course, as they have an increased risk of complications, including delirium, delayed graft function, longer length of stay. And I think really the big research question that's out there that hasn't been answered is, if we are able to intervene on any of these geriatric impairments, will we see improved outcomes in terms of hospitalizations, mortalities, home therapies, and transplant? And we also see, as I mentioned earlier, an increased risk of mortality. So those patients that have more geriatric impairments are at an increased risk of 1-year mortality. And specific impairments also put you at an increased risk, with the presence of frailty placing people at 7 times the risk of 1-year mortality. So I'd like to introduce you to my next patient. This is Frank. Frank is an 81-year-old male with a history of hypertension. He's had 2 strokes over the last year, a carotid endarterectomy, which was complicated by severe anemia in the setting of a GI bleed, lung cancer with resection, COPD, GERD, and a recently diagnosed melanoma on his face, who presented with his spouse for an evaluation of chronic kidney disease stage 5. They endorsed that since his stroke, he's had slow ambulation, unsteady gait, and some short-term memory impairments. His wife assists him with a lot of his activities, including cooking and finances. When you review his labs, you find that his creatinine is 5, his GFR is 10, he has hyperkalemia to 5.9, a mild acidosis, and a preserved albumin. His urine is significant for both blood and protein, with a protein to creatinine ratio of about 1,000. And on review of the labs, you find that he has had long-standing chronic kidney disease stage 4 for at least the last 3 years. So in this case, it looks like he does have, clinically significant chronic kidney disease, likely from maybe hypertension, and it is progressing. From a social standpoint, he works as an author, and he feels really frustrated by his recent medical setbacks, as he's always been very independent. He does not know if dialysis is for him, but his wife thinks that he should get it. So when we are presented with a discussion about something like dialysis, especially when there's a disagreement either between the doctor and the patient or between the patient and the family, this is a framework that I find helpful to work through. And that's reviewing medical indications, patient preferences, quality of life, and contextual features. So let's start with medical indications. So for Frank, we would want to identify the available treatment options. So for him, it would be discussing dialysis versus conservative management or non-dialysis therapy of his chronic kidney disease. We would want to estimate prognosis with both treatments, evaluate risks and benefits, and review any practice guidelines that might be available to help us. So who thinks that sharing prognosis would influence treatment choices? I think this is something that a lot of doctors, shy away from because, we're not 100% in terms of our prognosis. But this was an interesting study of dialysis patients. And the dialysis patients were asked, do you think that you have more than a 90% chance of being alive in 1 year? So they asked the patients, and then they asked the medical providers the same question. So 81% of patients said, of course, I think I'm going to be alive in 1 year. But the providers thought that was only true in a quarter of the patients surveyed. So a huge discrepancy in what the doctors and the providers thought the patient's prognosis was and what the patients actually thought. Those patients that had optimistic views on prognosis preferred life-extending care. But when they were asked, if you were seriously ill, what would you want? What would be important to you? 54% reported that if they were seriously ill, they would want care focused on relieving pain and discomfort rather than extending life. But as you can see, if we do not provide patients with our expectations on prognosis, then they are unable to make these decisions. This was another interesting study with dialysis patients, in which dialysis patients were asked, how long would you guess people at your age with similar health conditions usually live? Now, about 40% of the patients said, I have absolutely no idea, I'm not answering this question. But of those patients that answered the question, a third, 33% said, I think that probably greater than 10 years. In actuality, when we look at the average survival of patients receiving dialysis, the majority have a life expectancy of about 5 years or less. So again, this was a big discrepancy in what patients thought and what we actually see. For those patients that had those increased prognostic expectations of greater than 10 years, they found that they were less likely to have a documentation of a surrogate or other decision maker. They did not have any documentation of their treatment preferences, and they tended to value life extension over more, comfort-focused care. They were also more likely to want CPR or mechanical ventilation. So again, just highlighting the fact that how sharing prognosis can influence treatment choices. So really the question that I have when I see an older patient with chronic kidney disease and we're discussing dialysis is this patient at risk of poor outcomes? I do not have a crystal ball. I cannot predict the future. But, I do have some tools that I have that will help flag, patients who are at a high risk of potentially poor outcomes. So perhaps the easiest screening tool that all of us have is this surprise question. And the surprise question has been validated in various, clinical circumstances, including chronic kidney disease and end-stage kidney disease with people on hemodialysis. So the surprise question is when you ask yourself, would I be surprised if this patient died in the next year? And what was found with patients with chronic kidney disease stage 4 and 5, in those patients in which the provider said, no, I would not be surprised, they actually had a higher mortality than those patients in which the provider would be surprised. Similarly with hemodialysis. Now, this shows us that we do have, some insight as to who is at high risk. Who were these patients that the providers would not have been surprised? They were the older patients and the patients that had more comorbidities. So this is an easy screening test that you can use to initiate that conversation, as I'm concerned that, you might have a poor outcome with dialysis. What other information do we have? This study looked at 400 patients over the age of 65 who were started on dialysis and their 1-year mortality. And what they found was, several, easily accessible, factors that we could screen for that place people at increased risk of mortality. So the first was age. Those patients who were over the age of 85 had about a 70% 1-year mortality. Here in graph B, patients that had greater than 4 comorbidities had a 1-year mortality of about 60% after starting dialysis. Those patients that needed help with their ADLs, again, at 1 year, had about a 70% 1-year mortality. And those patients that started dialysis in the inpatient setting had about a 60% 1-year mortality. So again, this is, pretty easily accessible information in the medical chart that you can look at that would, again, flag someone as being potentially at an increased risk of a poor outcome. Now we get into a little bit more involved screening protocols. So the Charlson Comorbidity Index, this was evaluated from the University of Pittsburgh, looking at about 300 dialysis patients over a 2-year period. And this index provides a score to each patient based upon different comorbid conditions that they have here. So different conditions are given different weights, and patients are given 1 point for every 10 years over the age of 40. Based upon the patient's score, they can be stratified into a low, moderate, high, or very high comorbidity group. So this study again looked at hemodialysis patients and looked at the outcomes, including hospital admissions and mortality. And what they found was that for every unit increase in the comorbidity score, there actually was an increased risk of hospital admissions and an increased risk of mortality. So looking at this graph, for those patients in the very high risk group, which our patient would fall in, they had an estimated 1-year mortality of about 50%. This last study I'm showing, just because it's a little online calculator, which if you wanted to just play with, to look at, sometimes I find that that's helpful. And it's based upon a study that tried to really combine the comorbidity index and the surprise question to come up with independent predictors of mortality. And the study found 5 independent variables: age, the presence of dementia, the presence of peripheral vascular disease, and a low albumin, as well as an answer of no to the surprise question. And you can, put in your patient variables and it will give you an estimate survival at the bottom here of 6, 12, and 18 months. Now, you would never, ever, ever share these numbers with a patient or family, right? But this is just, again, you can use this to put in to help provide you with information of who may be at an increased risk. So, I think that going through this, we would agree that our patient, Frank, would be at an increased risk of poor outcomes after starting dialysis. So what would be the alternative for Frank? So the alternative would be conservative management. In 2010, the Renal Physicians Association guidelines defined conservative management as an acceptable and active treatment in which patients have the right to forego dialysis. And the language that they used here was very important, and they did so on purpose because conservative management is an active treatment. Conservative management is not just the default when somebody does not get dialysis. So what is conservative management? It's an integrated care model where you are still treating your parameters of advanced chronic kidney disease care. So you're treating anemia, their volume status, electrolytes, monitoring, making recommendations about nutritional changes, but it's also incorporating palliative care. We are looking to identify and treat pain and symptoms early. We are trying to provide physical, psychosocial, and spiritual care. We are engaging patients and their caregivers or decision makers in advanced care planning. And we are identifying times when they're having increasing care needs and recommending transition to hospice when that is appropriate. Now, for most patients, dialysis will offer a survival advantage. But there is a group of patients in which that is not the case, and that's really who we want to try to identify. Studies will vary, but on average, the median survival with conservative management can range from about 6 months to 1 year. This study looked at the intensity of care for older patients, particularly veterans with chronic kidney disease. So it looked at over 11,000 veterans with a mean age of 79 that were estimated to need dialysis in the next 2 years. Now, these patients either received their pre-dialysis care in the VA system or in a Medicare-based system. And those two systems have some intrinsic differences, fee-for-service, et cetera. But what they found was that in the Medicare system, more patients were started on dialysis, 82% compared to 53% in the VA system. In the Medicare system, more patients with dementia, more patients with metastatic cancer, and more older patients over the age of 80 were started on dialysis. Overall, the 2-year mortality was 47%, but they found that in the Medicare group, the mortality was higher, 53% versus 44%, suggesting that more intense care or more dialysis is not necessarily associated with improved survival. Now, most of the studies that we have regarding conservative management are from the UK, Australia, Canada. None really come from the United States, unfortunately. But this was a study from the UK that was a retrospective study of patients over the age of 75 that were estimated to need dialysis in the next 18 months. And they were part of this multidisciplinary practice where conservative management is very well defined, and they have a lot of support with social workers, nurses, and other providers. The endpoint that they looked at was a comparison of mortality in patients that chose conservative management versus dialysis. And perhaps not surprisingly, they saw a survival benefit with dialysis. Now, the top dark line are patients who received dialysis. This bottom gray line are those who opted for conservative care. So at 1 year, it was about an 84% survival in the dialysis group compared to 68% in the conservative care group. At about 2 years, it was 76% versus 47%. But then the authors tried to look specifically at certain patient characteristics. So they looked at comorbidity scores, defined as having at least 3 conditions. And when they specifically compared the survival of patients over the age of 75 with a comorbidity score, with a high comorbidity score of having greater than 3 conditions, they found that these survival curves overlapped, suggesting that the survival benefit was not apparent when controlled for patients with high comorbidities. They took it one step further and also looked at patients with ischemic heart disease. And they defined ischemic heart disease as patients with a history of MI, anginal symptoms, a positive stress or cath in the past, or with ischemic changes on the EKG. And when they compared patients with ischemic heart disease in this top graph, they also found that the curves were much closer and there was not a statistically significant survival increase with dialysis. This study from the Netherlands did something similar. It looked at 300 patients over the age of 70. But in this case, the patients were matched, so there was no difference in their comorbidity score. They were all pretty similar. And these patients either opted for dialysis versus conservative management. About a third of the patients opted for conservative management, and these patients tended to be older. 200 patients opted for dialysis. Now, what's interesting is that 40% of the patients who opted for dialysis did not ever get dialysis. They either died before starting dialysis or they did not progress to needing dialysis. And that's kind of what we talked about earlier, right? Just because somebody is expected to need dialysis or might have a low GFR level, they aren't necessarily guaranteed to progress to that stage. So what these authors did was they also looked at mortality but they looked at different time points. So they looked at time from when the decision was made, time from when the GFR was less than 20, less than 15, and less than 10 to see if there were any differences in mortality between the dialysis and the conservative care group. So this first column, this first column on the left looks at patients between the ages of 70 and 79. And what they found was that regardless of the time point, dialysis seemed to have a survival advantage, the top dark line being dialysis, bottom line again being conservative management. But what was interesting was that when they looked at patients specifically over the age of 80, regardless of the time point that they looked at, these survival curves overlapped, and there did not seem to be a survival advantage with either dialysis or conservative therapy. So the big take home from these studies is that in certain individuals, dialysis may not offer a survival advantage. Specifically in older patients over the age of 75 with high comorbidities or ischemic heart disease, dialysis may not significantly extend life. And in older patients over the age of 80, dialysis may not extend life. Now, these studies are not perfect. We will never have a randomized controlled trial looking at dialysis versus conservative care. There are too many confounding variables. And the outcomes that are looked at in these studies are only mortality, but there are other factors that are likely important to patients. So again, even though these are flawed, even though these aren't the most perfect studies, the take home is that though dialysis will offer a survival advantage to most, it is reduced or likely not present in certain populations, which we just defined. So we want to share this information with Frank. We want to share that uncertainty exists. Nothing that I can, say is going to be perfect. I can't predict what's going to happen. But I can tell him that given your age and your other medical problems like your stroke, you are at a high risk of setbacks and poor outcomes with dialysis, including a potentially limited survival. Life may be longer with dialysis, but it's not clear. I'm not sure. And I want to know, when you think about the time that you have left, what is most important to you? So Frank shares that the most important thing is that he is not in pain. He hopes that he will be able to regain some strength and energy with whatever treatment he chooses. He also wants to be kept upright. It's important that he can walk. He does not want to be bedridden. He wants to be able to think and enjoy time with his family. And he continues to work as an author. He was recently awarded this Lifetime Achievement Award and was invited to travel overseas for a public speaking engagement. He would also like to be able to travel for pleasure with his family. And he worries that dialysis would change what his life would look like day to day and it impair his ability to travel and to work. So we really want to focus on, quality of life at this point. So this was an interesting study that looked at patients over the age of 60 that had chronic kidney disease stage 4 or 5 who were not on dialysis. And what it looked to survey was what those patients really valued as their health outcome priorities. And what they found might surprise some of you, and maybe it doesn't surprise some of you, but the number one health outcome priority was maintaining independence. Number 2 was, increased survival. And actually 50% of patients ranked survival as their 3rd or 4th health outcome priority. So I think this really highlights the fact that survival is not always what people value as being the most important outcome of treatments, but we don't know what they value unless we really ask. So we want to frame a picture of what to expect with dialysis in terms of what life would look like, right? Dialysis is a commitment. It's 3 to 4 hours a session, 3 days a week. Some symptoms of chronic kidney disease might get better with dialysis, like nausea, but other symptoms will come with dialysis. So post-dialysis fatigue, where patients feel really tired and wiped out, is very common after dialysis. You would need a surgery to get an access place for dialysis. And what we find is that patients are often hospitalized to start dialysis. Almost 65% of patients start dialysis in the hospital, with over 1/3 of those patients being hospitalized for more than 2 weeks. In the year following dialysis, patients spend an average of about 2 months in a quote facility. So what a facility was in this study was either in the hospital, in a nursing home, or in a rehab. They found that as patients got older, they spent more time in that year following dialysis initiation in some type of facility. And that the longer time someone spent in these different places, the higher increased mortality that they had. I think this is my favorite study that I'm presenting today because I think it's very unique how they approached it. So this was a study of 200 patients with end-stage kidney disease who were over the age of 70. And they compared survival with dialysis and conservative therapy. So the top bar is patients who opted for conservative therapy. The bottom bar are patients for dialysis. And on the bottom axis is survival. So what they found, again, probably not surprising, is that patients that started dialysis lived longer, about 38 months compared to 14 months in the conservative therapy group. But what the authors then looked at was what they called time lost. So this was time spent admitted to the hospital, time spent traveling back and forth to dialysis, time spent receiving a dialysis treatment, and time spent recovering from that post-dialysis fatigue. And when they took that into account, they found that almost 48% of the days survived in that dialysis group were spent in this time lost category, compared to only 4% of the days survived in the conservative therapy group. So though life is longer with dialysis in this study, what the day-to-day life looks like is very different. So a question that we're often asked is, will dialysis help improve my functional status? So this was a study of about 200 patients around the age of 75 who were started on dialysis. And at the start, the majority of these patients were care dependent in some way. At 6 months, 40% of these patients had a further functional decline. 34% remained stable, and 18% had some improvement. This suggests, though, that functional decline, is common after the initiation of dialysis, and that dialysis itself does not mean that somebody will have an improvement in their functional status. And this is a typical disease trajectory, I think, that we see all the time with patients with end organ disease, including dialysis. They're admitted to the hospital with a clotted fistula, and they're there for, depending upon the hospital, a couple days, a week. And when they leave the hospital, they have a functional setback. So their functional status is a little bit worse when they leave than when they came in. Then they come in again a couple months later for an amputation. And similarly, when they leave the hospital, their functional status is a little bit worse. And this will happen over and over again until, the patient eventually dies. What do we see with conservatively managed patients? Now, again, very small study looking at only 46 patients, but this measured a patient's functional status using the Prognostic performance score every month from when their GFR was 15 until they died. And what this study found was that instead of that, kind of like roller coaster that we saw just in the previous slide, these patients tended to maintain their functional status up until the 1 to 2 months prior to death. So suggesting that perhaps with conservative management, one would be able to maintain their functional status a little bit more. What about cognition? This is also a question that we get a lot. Mom's more confused, mom's not as sharp as she used to be. Will dialysis fix it? Will dialysis be the answer? Cognitive impairment is very common in patients on dialysis, estimated up to 60% of patients having some cognitive impairment. CKD in itself is associated with a decline in cognitive and executive function. And we see that the transition to dialysis, though, immediately in like the short weeks following start, there might be some slight improvement in cognition. We see, over the course of months to years that there is a significant decline in cognitive function. And we see this more so with hemodialysis than peritoneal dialysis. We do see that there is actually an increased risk of stroke in the month following dialysis initiation, and this increased risk remains higher for a year. It's about twice as high in that year following dialysis initiation. So why do we see this cognitive decline? There was a study that looked at PET CT scans at different time points during dialysis. So early in the treatment, during the treatment, at the end of treatment. And what they found was that during the dialysis treatments, there was actually a reduction in cerebral blood flow. And the thought is that these subclinical repetitive dialysis-induced declines in cerebral blood flow just leads to repeated ischemic injury and eventual further cognitive decline. So lastly, we want to evaluate patient preferences and contextual features. So patient-centered care does not mean that we should blindly follow wishes. We want to understand the reasons why someone is requesting something. So if somebody's really requesting dialysis and we think that they're at a really high risk of having bad outcomes with it, we want to understand why they're requesting it. Is there a misconception of what quality of life will look like or what survival would be? Are there family or financial reasons that they are taking into account? We want to explore their hopes and expectations with treatment, identify concerns that they have for the future, and determine any limitations in quality of life or health conditions in which the patient would consider foregoing a life-supporting therapy such as dialysis. So we can frame it sometimes explicitly. Some people want to live as long as possible and will choose dialysis, even at the risk of frequent hospitalizations and less independence. Others wish to focus on the quality of life and prefer treatment focused on symptoms without dialysis, though this means that life could be shorter. Do you have a sense of how you would feel about this? And we can use what we've learned by speaking to the patient and their family to make a reflection statement and to use that in making a medical recommendation. So I would say to Frank that, it seems like independence is most important to you. And I worry that dialysis would increase the time you would spend interacting with doctors and hospitals and may be detrimental to your quality of life without offering you a survival advantage. And I think that conservative management of your advanced kidney disease would best fit with your goals. Now, we were lucky. Frank and his wife were totally on board. After we talked to the wife, she understood and she, supported his decision for conservative management. We discussed referring him to hospice at that time, but they were not really interested in having home hospice services at that moment, but were open for it in the future. So when can you refer somebody for hospice? You can refer a patient to hospice if they are discontinuing dialysis or if they are declining dialysis and opting for conservative management. If their creatinine clearance is less than 10 or their serum creatinine is greater than 8 or 6, though I think that this is kind of variable and you could speak to the hospice agencies to refer even if they're not at that specific cutoff. There should be some supportive documentation, so either hepatorenal syndrome, uremia, oliguria, hyperkalemia, pericarditis, or fluid overload. Technically, dialysis patients who want to continue dialysis and have a non-renal terminal disease with a prognosis of 6 months theoretically should be able to enroll in hospice and continue dialysis. So for example, diabetic kidney disease on dialysis is now diagnosed with metastatic colon cancer. They could be enrolled into hospice for the colon cancer and continue dialysis. Though I have to say this myself and speaking to other providers across the country, it's very, very hard to actually see this happen in actuality. So in terms of Frank, we conservatively managed him. We continued seeing him about every 6 weeks or so, did lab checks, used medications to help with his chronic kidney disease parameters. And the main symptoms that he had were really pruritus and fatigue. He was able to travel. He went on a 3-week trip with his family, and he was able to go on these trips to Egypt and England to engage in these speaking engagements. 2 years after we started seeing him, he started developing some new neurologic symptoms and seizures, and we were concerned. I was like, is this uremia? Is this something else? But he was actually found to have metastatic cancer and, unfortunately, brain lesions thought to be that metastatic melanoma that he had just been diagnosed with the 2 years prior. And at that point, we were transitioning him to home hospice, and he eventually passed away around his family. So in conclusion, the elderly population has unique clinical factors that we should consider when discussing treatment for advanced kidney disease. We have prognostic tools, including age, comorbidity scores, and use of the surprise question. We should engage patients and families in shared decision-making in which medical indications, patient preferences, quality of life, and contextual features are reviewed. Dialysis may not offer survival advantage in certain populations, including elderly patients with high comorbidity scores or ischemic heart disease, and may not improve functional or cognitive status. Conservative therapy with concurrent palliative care should be offered to these patients as an active treatment. So thank you again for having me, and I think we have some time if there's any questions.
I can start off with a question. Oh, Dr. Braun, after you.
Obviously, I mean, one thing, it's a beautiful presentation. Thank you so much.
Thank you.
But, you know, some of my questions are related to gender. Now, women tend to be more independent, men tend to be more dependent, especially in the older age group. I can't speak for the younger age group, which that's changing. So I wonder if that makes a difference in their preferences, because men can always rely on somebody taking care of them, whereas women are less likely to. So that's the one question. The other question I ask, for those people who break the odds, what about them? What are the characteristics that break the odds? Because patient will often say, well, so-and-so did X, Y, Z. So I think I may be one of that one instead of what my profile is showing, you know, based on whatever you know about the patient.
Right.
The third question is the time involved in helping the patients to educate. I mean, an example is a patient who's terrified of transfusion. They were terrified because it's foreign stuff. And they didn't realize that red cell transfusion was just red cells and nothing else, and why it was being given. So the denial for transfusion with hemoglobin of 5 was probably not a good thing, especially in the face of tachycardia of 160. So given those issues, it's the time required to explain and to understand what the patient really believes or understands, especially when there's cognitive issues or language issues or education issues.
Yeah, I mean, those are great questions. So the first question about gender differences, I have to say that I don't actually know any studies that specifically have looked at gender differences in terms of these preferences. But I can look into that and see if I find anything. I think that would be an interesting question to look at if it has not been looked at in this specific population. Your second question in terms of those patients who say, like, you know, oh, like my cousin Bob, like he had dialysis and he lived for 10 years, like why wouldn't I? Yeah, I mean, I think that happens a lot. And I think that in those times when there is a disagreement, we can offer, you know, sometimes a time-limited trial. So saying, okay, you know, what outcomes are you hoping to achieve with dialysis? You know, oh, well, you know, Bob, you know, his functional status got better. He was able to go, you know, go back to work or do what he wanted to do. So you can set that. So you set specific expectations. You know, we're going to do dialysis for 2 months. At the end of 2 months, we hope to have X happen. We hope to, you know, improve our functional status. If at that point we find that you're not having an improved functional status, or that, you know, dialysis is not consistent with your quality of life, then we can transition back to conservative therapy. And if, you know, you're not sure at that time point and you want to give it another 2 months, then we can do that. So I think that's a way to frame it. Your last question about time, yeah, I think that's an issue for all of medicine about education. You know, these other countries have really well-established conservative care practices. They have a lot of support. You know, they have social work, they have nurse educators, and we don't necessarily have that here. So it does take time, and these conversations don't happen in one visit. You know, these are conversations that happen over 2, 3, 4 visits. So it does take a lot of time.
Thank you. Dr. Maisels, do you want to go ahead with your question first?
Yeah, sure. Just one real quick question. Holly, thank you for an outstanding talk. So I was curious about a third option. You basically are presenting 2 options, you know, renal replacement versus conservative therapy. And I'm wondering about a potential third option, which I'm currently dealing with one of my 90-year-old patients who's really not interested in end-of-life care at this moment, but also very ambivalent about starting dialysis. in general, he's pretty functional, feels pretty well, and he wants to wait as long as possible, but he's not really ready for end-of-life care. But he does have some, mild uremic symptoms. He's lost some weight. His albumin's gone down. His B1's 120. His GFR is very low. And he's got a functional fistula. So in a younger person, I would say, you really do need to start dialysis, but he really doesn't want to. So what about a third option, which I'm sort of exploring with him, which is, listen, shared decision-making. We're going to wait until something is absolutely urgent, because I know you do not want to die right now. We take a risk that you may not make it into the hospital when something's urgent. You might develop pericarditis and have a problem. You might develop hyperkalemia and not make it in. But, at your age, if you want to take that risk, okay, it's fine. So what about that third option of wait for something urgent and then do it?
Yeah, I think that's always an option. I think that, if it's shared decision making, if they're, okay with that, it sounds like he's not fully ready to make a decision about conservative therapy, that, when push comes to shove, he does want dialysis. He just needs like a hard indication for that. And I think that's, I think that's appropriate. If that's what he wants, then doing that, as long as he understands that, there is a risk that, you might not catch the hyperkalemia in the, 2 or 3 weeks you go in between checking labs. I think that is an option. When they've done studies looking at patients, this was out of Australia, that opted for conservative management. Because the question I always get from people are, you do all this effort, you talk, you counsel, but at the end of the day, someone's going to want dialysis. And they've actually found that when patients say, I don't want dialysis, I want conservative management, they really don't change their mind if they have the proper support. Patients who say that they want dialysis are more likely to switch into wanting to be conservatively managed at the end of the day. So, but I think that's an appropriate way to handle it in your case.
Thank you. And I do think that would actually require some provider education and handholding to allow them to feel comfortable with the idea that, you're taking a chance with this patient.
Right.
But if the patient wants that, then you need to be comfortable with that.
Right. You can't force someone.
Yeah.
Thank you. Next, we have a question in the chat from Archana, one of our PGY3s. She thanks you for the wonderful talk. Is there any difference if they get peritoneal dialysis versus hemo in terms of survival and quality of life?
That's like a big debate. So in older patients, I don't know that there is a big difference in terms of PD versus HD survival, because older patients who have criteria for frailty tend to fail. I don't like using the word fail, but peritoneal dialysis doesn't usually work out for them, and they usually wind up switching to hemodialysis. In terms of quality of life, there are, some studies that suggest that, peritoneal dialysis does offer a better quality of life than hemodialysis. A lot of times, though, that's confounded by the fact that patients who have peritoneal dialysis, one, are either, and this is a generalization, but sometimes they're often more functional because they're doing this peritoneal dialysis at home. But also, when they are unable to do it themselves, they have family or friends that assist them with it. So there does seem to be like a better social support with peritoneal dialysis. And with that social support, sometimes other aspects like mood and can be better in terms of quality of life.
I see Dr. Seward has raised his hand.
Yeah, Dr. Koncicki, I'm wondering, I suppose drawing a little bit on my experience in caring for patients with malignancies, how often do you encounter an issue where patients are getting contradictory guidance from you, let's say, versus some of your colleagues in other specialties? And my experience with patients is they're apt to ask virtually every care provider that they see, and just wondered if you'd comment on that.
Yeah, I'm so glad you brought that up, because that's something I think is very important. And I should have mentioned, but when you're having these conversations with the patient and the caregivers, you have to have conversations with their other care providers as well, because patients need to be getting a consistent message. If, cardiology is saying you need dialysis, and then renal saying, I don't know if you're going to do very well with dialysis, like the patient, what is the patient supposed to do? They're hearing two contradictory messages. So we see contradiction all of the time. So it is really important to almost have, like you're having a meeting with the patient and the family, to have a meeting with the other care providers to make sure everyone's on the same page. On a similar note, if someone is opting for conservative management and then they wind up going to the emergency room for some reason, it needs to be clearly documented in the chart that the patient is opting for conservative management, because there have been times when someone winds up in the ER and the ER is, telling them, not to like rag on the ER, but the ER providers are like, you need dialysis. Like, what's happening? Why has nobody dialyzed you yet? And then again, they're getting contradictory messages. So it's really important to get everyone on the same page.
Very hard to get a conference together with other physicians.
Yeah.
My end up calling me because the other doctors, quote, don't respond. So
right.
It's for questions that are unrelated to what I treat them for. I mean, I never turn them down because obviously they're in a very fearful, uncertain stage. And so, but that's no question, time consuming, but I think it's an essential part of what we have to do. But trying to reach other physicians for a conference is very often a trial. And
yes.
We have to create a better culture for that. I'm not sure how we can do it. If you have any good ideas, I will certainly try them.
I mean, I don't know what you guys use at West, but I feel like the Epic chat on Epic has opened up communication with providers at, the East Side campus that, whereas, picking up a phone to get 3 people on the phone is very difficult, but to engage everyone in a chat, which maybe isn't perfect, but people seem to respond a little bit better. I think that's kind of changing the way that we're communicating and able to kind of rally everyone together.
Except when they don't have access to you.
Yes, nothing is perfect. Yes.
We do have one more question in the chat. So Fatma, another PG/3 asks, any comments on renal transplant versus initiating hemo in these patients?
Yeah, so so transplant is difficult because if you are waiting for a deceased donor transplant and you're older, then the time that you are waiting is probably not going to pay off in terms of the time that you're going to get with that transplant. Do we have patients who have someone that wants to give them a transplant? Yes, and I don't think that there's any like strict cutoff in terms of if you have a living donor that wants to give you a transplant, that would be kind of patient dependent and transplant center dependent. But I think it's also important to remember that in patients that have a lot of geriatric syndromes and are frail, they do tend to have worse outcomes with transplant. They have a lot of complications. So, I'm not going to say that it's not feasible, but, I haven't seen it that often.
Dr. Koncicki, thank you so much for a really insightful talk. And I assume you would agree that has broad applicability, certainly beyond HD and optimal care for our older patients. So really very grateful for the talk, and thanks for all the helpful hints around scoring systems and other ways to ask patients questions that really kind of get at the heart of what they want out of life, which is always the essential question. So thanks so much. Really great to have you today.
Thanks for having me. Have a good rest of your day.